So the outcome assessment is obviously key to all of this. You know, the intraoperative observations is something that we published together more than a decade ago, and I think the idea that you can assess very accurately whether or not a patient's ETV is going to be successful before the end of the case is something that I still believe in. And it has to do with the pulsatility of the floor of the third ventricle, the clarity of the subarachnoid spaces, and the success of the stoma creation. But there are a ton of other tools that are available, and the radiographic findings, as we mentioned, are widely published, and people spend a lot of time looking at and debating the various radiographic findings as they relate to the success of an ETV. Ultimately, on the bottom, I think the key for any medical student who's quizzed about this would be to answer that the clinical signs and symptoms of raised intracranial pressure are the most important. So if a child comes in with signs of raised intracranial pressure, the resolution of those symptoms or the improvement is going to be more important than any single predictor on an MRI scan. And that includes the turgor of the anterior fontanelle on a baby, or dilation of scalp veins, or positioning of the eyes. And so always go back to the clinical assessment, still more important. All of this literature is great, and it's important for us to study and to examine, but ultimately will come down to how you think the surgery went. Most surgeons can tell very, very accurately during surgery, I think it's going to be successful, and then how the child is doing post-operatively. And if you take those two, sprinkle in some factoids about the radiographic findings, I think you'll be in good stead. Again, let's not waste too much time going over all this MRI stuff. Take a look at some of the literature. It's in all of the slides. You can go back and take a look at some of those papers if you happen to be really interested in the radiology of this. There's a ton of literature, and people publish about it still to this date. It's just a question of the utility when compared against the clinical assessment tools that you already know about. It's a really nice phase contrast, the pulsatility that you can see on the right, that beautiful burst of CSF coming through there. That's a disrupted, proton spin signal there in the third ventricle. You know that there's a patent stoma there, but again, that's something you would know already from the time of surgery. So not only do you have that sort of turbulent flow pattern at the stoma, you can also see changes in the shape of the third ventricle, gyration in the sulcal effacement on the brain itself. All these things are interesting phenomena that you can identify when you become familiar with looking at these pre- and post-operative scans. These phase contrast sort of cine MRI scans became really popular to the point that patients started asking for them, and it sort of became a routine part of our analysis. I think there's a little bit of a technical limitation to this, and I don't use them all that much. When they come out nice and you can use them for an assessment tool, they're great, but I think there's a little bit of a technical variability in how they're done, how they're assessed, and how they're windowed. So again, take these all with a grain of salt, but they can be beautiful when they work, but the clinical assessment is always going to be more important than any of these MRI scans. One of the things in the ETV success score and in our, intraoperative assessment tool was the presence or absence of a previous shunt. I think we all understand intuitively that the presence of a shunt creates lots of problems with the potential for an ETV working, but it certainly should not be a contraindication to going ahead and proposing a shunt in the proper clinical scenario. So if you're seeing a patient on a rotation and they have a shunt malfunction, but you look at the scan and you think they've got aqueductal stenosis, and maybe the shunt was put in when they were too young or by someone who wasn't familiar with endoscopy, the idea of bringing up, well, maybe this is an opportunity to try an ETV and make the patient shunt independent is a completely legitimate thought process. And the idea of taking a patient who has a shunt and making them shunt free is something that's going to add such a quality of life to that patient that it's often worth doing. Sometimes you'll find, again, like we discussed, the presence of the shunt has somehow changed the absorptive capacity of the brain such that the ETV will never work, or the shunt was put in because of significant factors such as intraventricular hemorrhage or intraventricular infection, which is going to make the ETV less likely to be successful. But even if a percentage of those patients goes on to become shunt independent, it's worth it. And I wanted to include, but didn't have the time to get it into my talk today, a really interesting analysis of the last 20 years at our own institution, just a single institution study, looking at the number of shunt revisions over the 2 decades. And shunts used to be the primary reason why people didn't like going into pediatric neurosurgery. And, you're shuntologists and half your cases are shunts. And as we started introducing ETV and becoming more aggressive with the endoscopic tools that we have at our disposal, the number of shunts in our institution went down and the number of endoscopic procedures went up, and they just crossed about 3 years ago, such that now shunts are no longer the most common thing that we do at our institution, because our population within the greater New York City area has now seen endoscopy for 20 years and has literally lowered the shunt volume in our catchment area. So it's something that you won't see in a year or two, but over a long time has been really wonderful to see, and to think about all the shunt malfunctions and problems that have been averted in patients because of the introduction of this technology has been really exciting. So to bring together all the theoretical concepts that we learned earlier in the month and sort of bring them to bear on the reality of taking care of kids.
Hey everyone, Ryan Rad here from Neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.